In an earlier video, we talked about the functional brain domain of cognition and some of the most important cognitive functions. In this video, we will introduce you to cognitive psychopathology.
Reduced cognitive functioning is part of many psychiatric diseases. It can be a very characteristic symptom, such as in the case of psychosis, with its distorted perceptions. Or it can be a rather silent and well-hidden symptom under more conspicuous symptoms, such as mild intellectual disability under aggression or substance use. In any case, it's important to look for cognitive symptoms in the psychiatric patient, because untreated cognitive impairments often lead to reduced daily functioning and also a worsened prognosis.
Do you remember the cognitive functions that we mentioned in an earlier video? Let's list them again. The memory systems, the perception, the executive functions. If these functions are affected by disease, they tend to be associated with particular psychiatric symptoms. Should the working memory be affected, then symptoms such as attention deficit, loose associations, or disorganization might occur. Should there be disease processes involving the perception, then hallucinations and delusions can be the result.
In this table, we see examples of how disturbed cognitive functions can present clinically. The first column contains the normal cognitive functions. The second one lists examples of corresponding symptoms that can occur if the cognitive function is disturbed. In the third column, you see some psychiatric disorders in which these symptoms appear. A table could also easily be complemented with a fourth column that lists the brain regions that are affected when there are cognitive symptoms present.
When there is a disturbed working memory, often the prefrontal cortex is involved, and networks the prefrontal cortex is part of. In declarative long-term memory deficits, often the hippocampal region or other brain regions tightly linked with the hippocampus are affected. For non-declarative memory disturbances, the basal ganglia is often involved. In perception disturbances, then the sensory cortices or association cortices that process perception on a higher level are often affected. According to one theory, if combined with impaired frontal functioning, it can result in psychosis. For symptoms indicating a dysfunctional executive functioning, such as impaired impulse control, planning, and cognitive control, then networks including frontal regions can often be found affected. So in that sense, it's quite logic and intuitive. The same regions that mediate a cognitive function or other nodes of the neural networks tend to be involved when there are symptoms of this function being disturbed.
In this context, it is also important to remind you that most psychiatric disorders don't consist of only one symptom, or symptoms from only one functional domain, such as the cognitive domain. Actually, most psychiatric disorders are associated with symptoms from several brain domains, even though one or a few of them are more conspicuous and characteristic. This isn't very different from diseases of the body. If, for example, you have a heart failure, you often also have symptoms such as swollen ankles, maybe a shortage of breath, and affected kidney function. Partly the underlying reason in many cases has to do with the network architecture of the brain and the body. If one brain region is affected, often the disease spreads in the networks this region is part of. Also, the same region might have multiple functions, and if one of them is disturbed, then it isn't unlikely that other regions and functions also become affected.
One example of a psychiatric disorder where the cognitive symptoms are the most characteristic is OCD, obsessive compulsive disorder. You will later meet the virtual patient Tom, who expresses many of the characteristic features of OCD. A patient with OCD suffers from reoccurring thoughts and behaviors that he or she feels the urge to repeat over and over again. Common themes for obsessive thoughts include having things symmetrical or in a perfect order, fear of germs or contamination, and unwanted taboo thoughts involving sex or religion. It can also be aggressive thoughts towards others or self.
The repetitive behaviors that a person with OCD feels the urge to do in response to an obsessive thought are called compulsions. The compulsions often give the patient a direct feeling of relief, but only for a short while. Then it all starts over again. Common compulsions include ordering and arranging things in a particular way, compulsive counting, repeatedly checking on things, such as if the door is locked, excessive cleaning or washing. A person with OCD generally can't control his or her thoughts or behaviors, even when they are recognized as excessive by the patient.
Imaging studies have shown differences in the frontal cortex and subcortical structures of the brain in patients with OCD. More precisely, in a structural network called the limbic corticostriato-thalamocortical circuit. This circuit seems to be overactivated. Why this imbalance has occurred is difficult to say. Genetic factors seems to be important, given the rather high heritability, around 40 or 50%. Environmental factors too. OCD actually tends to break out after stressful life episodes. One important part of the puzzle seems to be that many patients with OCD have an underfunctioning specific type of serotonin receptor. And in some cases, children may develop OCD-like symptoms following a streptococcal infection. One theory is that this infection can cause autoimmune reactions to parts of the basal ganglia, and this is called pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, PANDAS.
Cognitive psychopathology is very interesting to study, but can be hard to treat. The more you know about the neurobiological basis, the easier it is to help the patient understand the reason behind their behaviors. This can also reduce the shame or stigma associated to many psychiatric conditions.